Newborn screening is critical for most forms of leukodystrophy, especially Krabbe disease, which is what my daughter had, because by the time symptoms occur, damage has already happened. One of the problems facing the public health sector is that private industry can pay more. So they will get lab technicians in, they will get trained, they will only stay for a couple of years, and then they will go to industry where they can make more money. Something that I wish I had realized earlier on was that it is okay to just be present when you need to be, especially if your child is still living and is still here with you. There will always be an opportunity to advocate.
Hello, ATS allies and caregivers. You are listening to The Rare Advocates, a caregiver-worthy and rare disease podcast brought to you by Aicardi Goutieres Syndrome Advocacy Association, where we update you with the latest news and conversations around Aicardi Goutieres and other rare diseases. My name is Betty, volunteer producer and marketing director, but most importantly, I'm a mom of 2 little ones, and the youngest one was diagnosed with Aicardi Goutieres. Now, let's take a brief moment before we get started and thank our sponsors. A special thanks to Biogen for sponsoring the podcast. And last but not least, do not forget to join the conversation. We're on all social media platforms, and please take a moment after the podcast and leave us a review wherever you're listening to us from. In this episode, we explore the critical world of newborn screening for leukodystrophies. Join us as we unravel the significance of early detection, cutting-edge technologies, and the expert guiding us toward brighter outcomes for these rare genetic disorders. Let's dive into the heart of neonatal care and learn how newborn screening shapes the future of pediatric health. Okay, so now I'm going to go ahead and bring my guest to the screen. Hi, Lesa. How are you doing?
I'm great. How are you?
Wonderful. I am so excited to sit down and speak to you because I am definitely new to the world of newborn screening, and I feel like there's so much to learn about. So let's just start off by, if you could please share with the audience a little bit about yourself. So introduce yourself and a little bit of your background in newborn screening.
Sure. My name is Lesa Brackbill, and I am the Director of Advocacy for the Leukodystrophy Newborn Screening Action Network, or as we call it, LDNBS. And I got into newborn screening when my daughter Victoria was diagnosed with Krabbe disease in 2015. On diagnosis day, we were told a lot of things, as we all are, but the words that stuck in my mind the most were, if you had caught it at birth, you could have treated it. And those words have transformed my life. And so I've dedicated the rest of my life to creating a legacy for Tori, because I couldn't help her, but I can help others.
Oh my goodness. I hate that we have to hear diagnosis day, but it really just changes and pivots everyone's life, whether we want to or not. So let's just dive deeper into the actual diagnosis day. So why is newborn screening so crucial? Especially, let's just talk about, in this case, leukodystrophy, because that's what we have in common.
Newborn screening is critical for most forms of leukodystrophy, especially Krabbe disease, which is what my daughter had, because by the time symptoms occur, damage has already happened. And right now, scientists have not yet figured out ways to repair myelin and to repair the damage that has already been done. They can only prevent the damage from happening. So in Victoria's case, by the time she became symptomatic at 5 months old, it was already too late. There was so much damage that they can't go back and reverse it. But newborn screening allows for treatment to be administered before symptoms even begin. So it gives the baby a fresh start at a healthy life that otherwise can't be obtained.
Yes. So for Aicardi Goutieres syndrome, I'm not sure how much you know about it, but it's a leukodystrophy, and it's exactly the same thing. It affects the myelin as well, and by the time a lot of parents start noticing symptoms, it's already been, for lack of a better word, activated. It's already progressed enough for it to be so significant that we see it. It is clinical now. And we do have a treatment. We don't have a cure for Aicardi syndrome. And if only we could start the treatment immediately upon the diagnosis, before the diagnosis starts showing itself, presenting itself, it would make a difference. Even though, again, we cannot cure it, it right now shows it can slow it down and prevent like further damage. It is progressive for us, but it's definitely the slowing down is so, so crucial. But tell me now a little bit more, how does early detection impact prognosis? I'm still focusing on the day of, why it's crucial to start immediately.
With Krabbe disease, they can either do a stem cell transplant through bone marrow, or now there are gene therapies in clinical trial. And so what happens is, because with Krabbe, there's usually a deletion in a gene. So in our case, it's the 14th chromosome. And so the gene is just missing the ability to produce an enzyme. And I think that's the case for most genetic diseases. There's just something very, very small in our DNA that is either missing or it's misformed. And so without that enzyme, toxins for Krabbe disease, toxins build up in the brain and the nervous system. And I love, even though I don't love the toxin, I love that it's called cycosine because it sounds very sinister, and that's exactly what it is. It's a very sinister toxin that destroys the brain, destroys the nervous system. And once that toxin has done all of the damage, you can't do anything else. But the babies that we have seen be diagnosed through newborn screening, because now 12 states screen for Krabbe disease, the results are remarkable. Some of these children you would never even know have Krabbe disease. And so that's the hope that we have with newborn screening is early detection, early diagnosis, early treatment.
And this newborn screening network, it's right now focusing the efforts on leukodystrophies, all leukodystrophies.
The Leukodystrophy Newborn Screening Action Network, our goal is to empower parent advocates across leukodystrophies and lysosomal storage disorders, because several leukodystrophies are also in that disease group. And our goal is to educate and empower parents, because newborn screening is very complicated. Not everybody needs to have the amount of knowledge that I have obtained through my research and my study. We shouldn't all be trying to create our own spreadsheet, our own databases. We all have different giftings, and mine happens to be research and education and communication. And so that's been our goal, is to also encourage people to help each other across leukodystrophies. So for example, I've been doing a lot of work with the metachromatic leukodystrophy or MLD community, because why should we just hold all of the lessons learned within Krabbe disease? Why shouldn't we be helping other leukodystrophies who are in different stages of newborn screening? So for instance, with the AGS community, I had spoken with a few of your community members a couple of years ago about obtaining the dried blood spots to validate the assay. And I didn't know a lot about it, but I took the time to connect them to people who would know, because I want to do what I can to help you guys get further along.
Yes, thank you. Are you talking about Ashley?
Yes, and Patrick.
Yes. So we interviewed Ashley. The last podcast came out, and we're, again, volunteer parents trying to cover a lot of bases. And I love that the network really helps us, like you said, not recreate the wheel or not start from zero, because there's a lot of learnings that have been gained, systems that have been applied, and a lot of knowledge that that can be shared so that we can all move forward and really help future families get access to everything that we didn't get necessarily immediately, that we wish we would have had, and that, can be depending on what the diagnosis is, the different options that may have. One of the things that I am not familiar with is, what are the technologies now used to put together newborn screening for leukodystrophies? Like, how does it work? Like the actual newborn screening, is it very complex, and that's why the states are not offering it for all leukodystrophies. I would love to learn more about the complexity behind it.
It is incredibly complex on many different levels, but we can even start with just the scientific level. Most of the leukodystrophies that have a newborn screening assay have Dr. Michael Gelb from Washington to thank for that, because he is a biochemist who has taken his passion and his knowledge and transferred it to the leukodystrophy community. And we're so grateful, because without him, we wouldn't have a newborn screening assay. So it takes scientists who have the know-how to figure out how can we tell from some dried blood whether a child has a condition or not. That's way above my knowledge base or pay grade.
Yeah.
So I'm so grateful for scientists like him who care. But then when you come into the actual newborn screening program side, it is a public health program. Newborn screening is a mandatory public health program that has been in existence since the 1960s. And so because it is run by states, which means that every state screens for different things, every state is responsible for how they run their program, for the equipment that they use and are able to pay for the staffing, all of the logistics that would go into screening for however many thousands or hundreds of thousands of babies are born each year in each state. And so that's just one piece of the complexity. The equipment that is used for most leukodystrophies is called a mass spectrometer, and those are about $500,000 each. And so thankfully, for a lot of leukodystrophies, they can actually be screened at the same time as other conditions, which is called multiplexing. So Krabbe disease, for example, can be screened on the same dried blood spot as Pompe, MPS 1, Niemann-Pick, Gaucher, and Fabry. So they can take one little dried blood spot, they can screen for all 6 of those conditions at the same exact time. And that saves the states time and money, but they still have to have people who are able to run the tests, read the tests, deliver the results to the families. You know, there's so many layers to this. And so I know it's very easy to feel very frustrated, because you're like, why can't this move faster? Why can't states just be screening for everything? And I admit I used to feel that way, because I didn't know as much as I know now. And now that I've been able to observe it from most of the aspects, I'm able to kind of step back, calm down, and say, okay, it's not that they are our enemy. It's not that they don't want to screen for it. Some states literally can't. And what are the barriers that they are facing that we can help them overcome as an advocacy community? And that's what my work in Pennsylvania really focused on.
Oh, wow. I'm so glad you're explaining it to us, because to me, it's from far away, it's a frustration. It's like, why wouldn't you want to help families immediately? Why wait until it gets more out of control? And from my point of view, as you know, I've been in this world for almost kind of 2 years. It's, could you potentially save money in the long run by providing families with a clearer path towards resources, treatments, and so forth? And I'm in Texas, so to me, it's it's very, very tough, because I see how much it differs from different states, and I'm sure almost every other person can say that about their state as well. So it worries me a lot, and even though it's no longer my problem, it's still my problem. Does that make sense? Because, I already been my family has already been diagnosed. We already work with a genetic counselor, but to me, it's just like, what about the future families? I just want us all to progress and move forward and go towards the right direction. And you said, you finished it off with some sentence, some states can't even, they can't even. When you say this, are you basing it off money? Because you said, it's very complex. Do you need the machine? So it's mainly money based?
Money, but also available staff.
Yeah.
So again, there's so many layers to this, and I'll try to remember what I was going to say. But I also want to start with saying, I'm not saying this is not a frustrating situation.
Yeah.
It absolutely is, but I'm less angry. I should have said that. I'm less angry about it and more motivated to help these states fix the problems that are keeping them from screening for everything. So one of the problems facing the public health sector is that private industry can pay more. So they will get lab technicians in, they will get trained, they will only stay for a couple of years, and then they will go to industry where they can make more money. And I mean, you can't really blame people for that,
No.
but there are staffing shortages. There's obviously state budget shortages to buy equipment, because if people don't understand what, and by people, I mean legislators, if they don't understand what newborn screening is, why would they increase the budget to pay for things? So there's a lot of lack of education that's going on. But when I say this, some states can't, that was truly the case here in Pennsylvania. I've seen it in other states like Virginia. Virginia actually published a paper in Pediatrics about why they chose not to screen for Krabbe disease. And at first, I was upset that they chose to even publish something that negative, until I read it carefully. And I realized what the paper actually was doing was highlighting all of the inadequacies of their newborn screening program. So then I saw it more as a checklist of, here's what we need to fix. And I only was able to see it that way because of what happened here. I started attending newborn screening advisory board meetings 3 weeks after Tori died. And as I was sat there and I listened with fresh ears, with ears that have no idea how a program is supposed to work, I picked up on things and I started asking questions. And I said, like, why are not all hospitals screening for the same thing here? Why do we have to have a newborn screening fee that's what we wanted, was a newborn screening fee. Why do we have to go to the legislature every single time we want to add a condition? And the list goes on. There were so many issues here. And so what we did is we fixed those issues. We gave the newborn screening advisory board the authority that they should have as the actual experts on newborn screening and these genetic conditions, to add the conditions that should be screened for. So we don't have to go to the legislature anymore. We don't have to go to politicians who know nothing about public health, newborn screening, or rare disease, and try to plead with them to add a condition or to give us money. So sometimes that's what it takes in each state. And every state program that I have interacted with is incredibly passionate. And they are in newborn screening. They stay in newborn screening because they know of its importance and they care about it, even though they can make money, so much more money anywhere else. And so it's just important to remember that we are on the same team. And sometimes as advocates, we can actually help solve some of these problems that they cannot. Like Department of Health officials cannot lobby. They cannot. And a lot of times hospitals have restrictions on their doctors as to what they can do to try to change policy. But as parents, we have no rules. We can do what we want, when we want. And I think that's a superpower that we have that we need to embrace more often.
Oh my goodness. Yes. Yes. I mean, everything you're saying, it's so full, so insightful, and so full of information that one has to really pay attention to and digest and be exactly asking the question, well, what power do I have? What can I do about it? And you mentioned the newborn screening advisory. That's who you should search for per state?
Yes. And our website actually has all of that information for every state listed. But 48 states have a newborn screening advisory board. In fact, I actually just gave public comment at the Texas meeting. That's a hard word to say. At the Texas meeting last month. And every state, of course, gives different levels of authority to their advisory boards. But generally, it is those boards that get to recommend conditions to their equivalent of a Secretary of Health or whoever it is in the state that actually has the rubber stamp authority to say, yes, let's do this. And the advisory board understands the logistics in the state. They understand all of that. But a lot of times advocates and advocacy groups tend to want to just go above that and legislatively mandate conditions. And that's something that I've seen more harm than good be done. And so we recommend going through the people who actually understand the system.
So kind of walking back to the beginning of that question. So for myself, if I wanted to become active, I would go on your website, which is the newborn screening, leukodystrophy newborn screening. It's so many letters.
I know.
Say it for me one more time.
Leukodystrophy Newborn Screening Action Network, or
Action Network.
ldnvs.org.
Yes, thank you. And I will go ahead and add, if you're watching this podcast, I will go ahead and add a picture of the website. And then I look it up on my state, and that's who I reach out to, correct?
Yes, we have links, and I have a spreadsheet it's actually my favorite project. It's hundreds of hours of research that have gone into detailed information for every single state so that advocates can get a better idea of what they're facing, which leukodystrophies are currently being screened for. I think it's pretty awesome, but I also love spreadsheets. Not everybody does.
It is pretty awesome. And for you to still be doing all of this and be so passionate about it, because it's just, I'm at a loss of words because I don't ever want to speak for anybody else. But to me, when I volunteer, I do it because I love Noah so, so much, but it's also hard still. I love volunteering. I love doing what I do, but I'm still hurt. It still hurts. And I still kind of like live in both worlds at the same time. So I'm very thankful for other parents who, if the opportunity presents themselves and they want to do it, it really helps everybody. So I'm very thankful for that. And also, as we're talking about, where to go and how to look up for help and really understanding the status, right? Because that's a big thing, the status of where your state is at, like whether they're currently testing. You mentioned kind of like an ethical piece to it as well, because there's obstacles that prevent them from doing it. And I didn't think about it like that either. It's like, you don't want to say you can't do it without having that very strong foundation. And you're changing people's lives here. So I didn't even think about this piece at all.
Yeah, there is definitely a lot more to this than I ever would have imagined 8 years ago. And because it is a public health program, because parents don't even often know newborn screening happened at all, it's very, very important that whatever conditions we are screening for, the test is very reliable. Like, they want to see almost no false positives, because they don't want to cause, even though I have a love-hate relationship with this phrase, they don't want to cause undue stress to parents. And I can get that, but I also always say, this is undue stress, finding out we can't fix it. But anyway, it's okay. So the test has to be reliable. The condition has to be pretty well understood. So in terms of like genotype to phenotype, can we predict the course of disease so that we know what treatment or when treatment needs to be administered? Because like with Krabbe disease, there are 4 different onsets of the disease. With MLD, there are also several. And I would assume with AGS, it's similar. Most leukodystrophies have different severity levels. And so they need to kind of understand, if the child has this gene mutation, what is the disease going to look like? Because they obviously don't want to treat somebody that doesn't need it. That would be a very bad situation. So the third component of all of that is that there has to be a treatment. There has to be a treatment, and they prefer for it to be like FDA approved treatment so that it can be obtained by everybody. Because, Medicaid, a lot of kids with leukodystrophies and with other rare diseases end up being on Medicaid because of the enormous financial and insurance burden that comes with caring for a child with a rare disease. And so there's a lot of equity and social justice pieces to newborn screening as well. And I was very surprised to learn all of those things, but it makes so much sense. Like, you cannot force parents to have their child screened for something only to say, sorry, you can't be treated for it in our state. So that's why they're very careful about what they choose to put on, especially the federal recommended uniform screening panel.
Oh, you're just, with every passing minute of this podcast, I'm just like, oh man, that makes sense. That makes sense. Because for those who are still fairly new to Aicardi syndrome, we have 9 genes that we know of. And then we have early onset and then late onset, right? And then in addition to that, we have 3 different like buckets of how severe the kid can be. And so that kind of leads to my next question. So let's say in a different world, a parallel world, we were testing for all leukodystrophies in all states because there was a lot of things would have to align. There was at least a treatment offered, right? But
Right.
how would that happen? Like, let's say I have no signs of any sort of symptom that lead to me suspecting this, and that kind of happened to me. And my son was born kind of almost still in time. He would have waited the NICU, and he showed no signs until 4 weeks later. So how would I know to ask for newborn screening when I don't know what my future holds? But I would have definitely benefited from that. Can you I know it's a very particular situation, but I think at least for the Aicardi syndrome world, it happens. They're born and it's not before they're born that we know. So can you explain if you can share some information on that?
That is exactly why newborn screening is mandatory.
Oh, mandatory. Okay.
Yes, it is mandatory. You can opt out for religious reasons in, I think, every state, but that's why it is mandatory, because we had no idea that we carried something like Krabbe disease. We have no family history of it. There's no reason to suspect it. And so it's considered to be a public health initiative because of that. Every child is at risk. We don't know. And they estimate that about 12,000 babies every single year are diagnosed with a newborn screening condition. And that's not insignificant. That's a large number of babies whose lives are changed by newborn screening. And so it's because of the lack of knowledge of carrier status, which I also would love for prospective parents to be offered carrier screening. Wouldn't that be amazing for you to go into pregnancy being much more aware of the potential of what your child could have? And some doctors do offer that, but not very many yet. And another thing that is coming that will kind of transform this, that will give parents even more knowledge this will be after their child's born, but rapid whole genome sequencing is being piloted in several different hospitals in the world. And its potential is incredible because right now, at most, states screen for about 80 conditions. And again, that depends on how the state counts the conditions. Some states will count every possible thing that they could catch, like California. California will say we screen for 80, whereas other states say they screen for 30 something. So just keep that in mind when you hear about the states and how many they count, because often it's actually more similar than it sounds. But anyway, rapid whole genome sequencing, in contrast, right now can identify about 400 genetic conditions that have a treatment. And right now it is a consented program, so parents have to opt in. And it's in addition to newborn screening. It will never take the place of traditional dried blood spot newborn screening, but the potential is enormous. And right now, the biggest pilot in the United States is in San Diego at Rady Children's Hospital. And they can actually do the sequencing in about 12 hours.
Oh, wow.
In contrast, for those who have had to go through whole genome or whole exome sequencing for their child, you know that it can take months.
Yeah. Yeah. If you're lucky, weeks.
Yes. So there are incredible things that are about to happen that will give parents even more treatment options for their children.
Yes. And with this pilot happening in San Diego, is it going to be up to the state whether they adopt it or not? Or is it going to be per hospital or state again?
I would guess state. All of this is so very new. Like within just a couple of years, this all started happening. And so states are already starting to wrestle with questions like, okay, if we do this, where do we store the data? Who stores the data? Do people trust the state to store the data?
Lisa, where do you have to bring me back to reality?
I mean, these are really good questions, especially coming out of the pandemic, where I was actually just researching for a grad school paper about public trust in things like public health and in the government. And right now, because of a lot of misinformation about public health in particular, there's kind of a negative connotation attached to it. And we don't want to see that same connotation attached to newborn screening. We want newborn screening to remain trustworthy. And so because of that, we have to think about what we do with the data.
My goodness, this is a lot of information, but a lot of information that we have to know so that when they ask for like the dry blood cards or something that we can do to contribute and help things move forward, we can actually take the time and ask for it and do it. Because if I'm correct, it also varies on every state how long they hold a card for, right?
Yes.
So many things, so many. And it makes sense. I mean, how many are they going to store? Do they have the room to store them in? So I see what you're saying, Lisa. I really do. Um, Now, with the upcoming innovations and technology, so you would have the option of newborn screening. And I guess if the baby was presenting further symptoms, such as the most common one, like staying at the NICU longer, I think is that the most common, like, I guess, signal of that something could be wrong?
That is how the pilot started, yes,
Oh, okay.
was doing genome sequencing or rapid whole genome sequencing, sorry, of the NICU babies, yes.
Okay. Okay. So I'm following you, Lisa. I'm learning quickly. Um, that's when they would present the opportunity of opting into that program. Makes sense because, oh man, it's just so many pieces. But the primary goal is, if there's something going on, catch it sooner than later, and even catch it before you leave the hospital, because that's when
Yes.
you I guess it's like a window of opportunity to get you started on the right track to getting access to treatments.
Right. And the doctor who is behind the pilot, his name is Dr. Stephen Kingsmore. He is incredible. And I've had the opportunity to hear him speak a couple of times. And one of the times he spoke, this is a paraphrase of his quote. I quote it all the time, but this is just a paraphrase. But he basically said, every single day in the United States, thousands of children are dying needlessly with approved therapeutics that are available. But because they're not being diagnosed early enough, they're not getting those treatments. And he used the phrase that there's a gnawing urgency to this. And I loved that because he's right. What good is an approved treatment if no one can access it? So there are so many moving parts to all of this, as I'm sure you and everybody listening can see. But everybody is working in their own little camp to bring this all together so that we are getting these babies access to treatment. And I think the goal is eventually to roll it out to even non-NICU families as an option. But from what I understand, the general ethical thought right now is that it will always be an opt-in.
Yeah.
It will never be just blanket like newborn screening is now, where everybody is screened, because they want to make sure. I mean, genetic privacy is obviously a big deal.
Yeah, well, and it's also that's even going farther, but making sure that all doctors are up to date, that they can offer this option and be aware of like the signals or symptoms that present themselves that would qualify for it. Because, I'm sure it's like going to be like, oh, if you're not showing this, then that's not an option. Because I know
But
of
think about
cases.
our kids.
What
Think
was
about our leukodystrophy kids who are declared to be perfectly healthy. And then you find out, in our case, 5 months later, that is absolutely not the case. And I remember Tori's neurologist saying to me at one point, because I said something about like, I'm so glad we had those 5 normal months. And she said, Tori was abnormal from the beginning. You just didn't know it. Because it's true. Like, there would have been little tiny signs, but I wouldn't expect any clinician to pick up on those. And that's why we have tests like newborn screening.
Yeah. 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 And I think that gears my anger towards it shifts towards a different way. Because for the longest time, I was just so frustrated with like, how can they miss so many signs? Like, I told them explicitly that this was going on, and then I take it back a step farther. I'm like, if only, we would have ended up in the NICU, or if only someone would have said, let's talk about carrier screening, and it's just so many moving pieces that, we need to push forward towards. We need to challenge the system and improve the system so that the system doesn't fail us along the way and can just diagnose us a lot sooner.
Absolutely. And I think that also needs to go toward, when we talk about carrier screening, family planning purposes. if we knew, and of course, hindsight's 2020.
Yeah.
I don't know what we would have said if we found out, oh, you both carry a mutation for infantile Krabbe disease. I don't know what we would have done. But I think that it's wise and the right thing to do to offer parents options in those cases. Like with our twins, we have 5.5-year-old twins now, and we did IVF. After we had Tori and she was diagnosed, we realized it was not wise to have more children naturally. We just could not do that. And I think IVF needs to be made more accessible to families like ours who are known carriers of genetic conditions, because as you mentioned earlier, saving money. Like insurance companies always want to save money, and the cost of IVF compared to the cost of a child with Krabbe disease is almost nothing.
Yes.
And so I really think there's so many improvements to be made across the board for rare disease families.
Yes. 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 I mean, it's so interesting how our lives, even though they're different leukodystrophies, like they're so similar still, and hearing your story, it's like you're talking on my behalf. You're not doing it on purpose, but my son was diagnosed at 5 months, and, immediately I was like, okay, well, I can't have more kids, and it's so expensive, and have to focus on the present, and it's just so many things. And you mentioned a really key question. If I would have known the odds, would I have still tried? And I guess it all depends, because, it depends on who presents it to you, who
Right.
who encourages it, who supports you, who makes it less scary, because everything is scary because it's so unknown. So so many factors. But looping around back to the Leukodystrophy Newborn Screening Action Network, is how many volunteers, or how many, what's a team look like, of how many people, because it's a whole lot of ground to cover. So I like to I want the audience to understand more what you'll do, and like how many people, what's the machine powering it, because it sounds like you do a whole lot.
Yeah, it's basically me that coordinates everything. And it kind of just depends on the situation, because right now for most leukodystrophies, we are all in this kind of a waiting period. And I don't want to be in a waiting period. I want to be in an action period. But sometimes the wise thing to do is wait. So with Krabbe disease, for example, we are in the process of waiting to see if the federal committee that decides conditions that will be on the federal recommended uniform screening panel. There's so many long words and phrases in this world, but they call it the RUSP. We are waiting to find out if Krabbe disease is going to be added to the RUSP. And this is after a years-long ordeal led by the Hunter's Hope Foundation mostly. And it's been a wild ride. And so we're waiting, and we may not know until May. So in the meantime, state-to-state advocacy doesn't necessarily make a lot of sense. There are a lot of states that have decided they're only going to add conditions that are on the RUSP, which I understand. It saves them time, energy for vetting conditions if they just go with what the government says. But for MLD, we are waiting on a couple of things. We have a gene therapy that is up for FDA approval, and we're expecting that approval on March 18th. Very specific. March 18th. So then we will submit to the RUSP. So with MLD, even though we have we have a newborn screening assay that works, and it's being used in parts of Europe right now, and we have almost an approved treatment, we need to just wait. So in the meantime, we have been gathering family stories and creating fact sheets for MLD families, and then Krabbe Connect has actually been doing them for Krabbe families, so that we can be not only gathering the family stories, preparing families to share their stories when it's time, but giving them something tangible. And all of these can be seen on our website or Krabbe Connect for the Krabbe ones. And so that's what we're doing right now. And so I don't have a set number of people, but we're just constantly engaging with the families and doing what we can. Another thing that I recently created that I'm very proud of is a strategic plan, or more like a roadmap, for how I see newborn screening going for both Krabbe and MLD. And that was the result of my big spreadsheet I mentioned that has a ton of data, but not everybody likes spreadsheets. I was thinking through, how do I make this more accessible to everybody? And so I broke it down, and I was able to then create a timeline basically how I think it's going to go. And so I try to create resources like that for families as well, because I know so many people want to do advocacy. They want to change the course of their disease for other families. And as I always say, advocacy is how I continue to be Tori's mom. Like, this is how I am her mom, even though she is no longer living. And so I want to help do whatever I can to make this a little bit easier for families.
You are making an impact and you're inspiring people. And for those who know someone affected by Aicardi syndrome, and you can always reach out to our Advocacy Association and see where we stand and what we're doing to help with newborn screening. So in case we need more volunteers to help Lesa, and Lesa can help us, please reach out to any of the volunteers, myself or Patrick or Ashley. And the thing is to keep the ball rolling, because we all have seasons where our kids get sick and it's really hard to move things forward. So sometimes we need to pick things up again and learn from people like Lesa, that compiled this information and created a roadmap for us. I know you were talking about the roadmap for other ones, but it's something that we can implement for us as well. So I'm very,
Absolutely.
very thankful, Lesa. I do have one last question for you, Lesa. What advice do you have for our listeners? And let me tell you a little bit about our listeners. Right now, those are caregivers or parents directly affected by them. By Goutieres syndrome, leukodystrophy. And then sometimes we have family members who know someone, right? And maybe they don't have kids. So this can be like a scary topic for them to be like, I want to have kids, but now we're talking about leukodystrophy and newborn screening is not available in every state. So just what piece of advice do you have for either one of those audiences or both of our audiences?
I would say, to go off of something that you had said, it is okay to realize that you are not in a season where you can or should be advocating. Something that I wish I had realized earlier on was that it is okay to just be present when you need to be, especially if your child is still living and is still here with you. There will always be an opportunity to advocate. But if you're like me and you're stubborn and you want to just get out there and use, like, this was always supposed to be my story, and I can't deny that. My education, my experience, my skills, it was so clear to me on diagnosis day that this is what I was supposed to do. And so if you were in that camp, then go for it. But make sure that you are willing to listen to the other stakeholders, to listen to those who have gone ahead of you, because there's so much to learn. It sounds like I know everything, but I absolutely do not. I learn something every single conference I attend, every webinar I listen to. I'll pick up new little pieces of information that help me be a better advocate. So I would just encourage you to always approach this with an attitude of humility and being willing to listen to understand. Be passionate, of course, be bold in your messaging, but approach everything with respect. And just remember that, yes, you have a very important role to play, because this is your lived experience. But so do the other people that are part of the ecosystem.
Lesa, I cannot thank you enough for taking time out of your day to speak a little bit about your family, mention Tori and share Tori with us, who inspired you and who you love very much. And I'm so sorry for everything you've gone through. Like, I wish I didn't have to meet parents this way, because I, to an extent, understand their pain. And I'm like, oh man, I wish we would have met in a parallel life, but it's what we have. And it's been an honor speaking to you, teaching our audience, encouraging us, and helping us understand this very, very complex world, but also painting a better future. And I like that. I appreciate that. It's encouraging, even though it's not my future, but it's the future of my other kid who's also a carrier. So thank you so much for taking the time and sitting down with us.
Thank you so much for having me.
Okay. Well, for the audience, I will go ahead and share all of Lesa's information, her socials, and for the Newborn Screening Action Network. I will share that. And Lesa, if you have anything that you want me to include in the description box, everyone check it out. I will have that for her. And thank you so much for joining the Rare Advocates. We'll speak to you soon.